I'd like to invite our next chairperson who is present with us physically, Dr. Surendra Thalor, sir. Sir is a graduate and MD from the prestigious Institute of Medical Sciences, BHU, and is currently the Associate Professor in the Department of Skin and Skin in SMS Medical College, Jaipur. He has various publications in national and international journals, and his keen interest is dermatology, dermatosurgery, and lasers. Next, we have Dr. Savita Agarwal, who will be joining us virtually. She has a clinical experience of over 13 years in the field of dermatology and has been a clinical associate in Lilavati Hospital, Mumbai. She was also attached with Mahatma Gandhi Hospital, Jaipur as an assistant professor for 5 years. And her researches have been published in various national and international journals. I'd request Surendra Thalor, sir, to invite the next speaker for the session, Dr. Shazia Jeelani, ma'am.
So we go for the next session, and the topic is occupational dermatosis in healthcare workers in COVID-19 pandemic. I invite Dr. Shazia Jeelani for this topic. Ma'am, over to you. We are not able to listen, ma'am.
Good afternoon, everyone. Am I audible?
Yeah, you are audible, ma'am.
Okay. I will just share my screen first. Is my screen visible?
No, ma'am, screen is still not visible.
Okay, just a second.
Please open it and then share the screen, please. Now it's visible, ma'am.
Okay, thank you so much. So first of all, thank you for the opportunity. I would like to share my views about the occupational dermatoses that we as healthcare workers are facing in this COVID-19 pandemic. Okay, I have no conflicts of interest and no financial disclosures. So the pandemic of 21st century, COVID-19 came with a very high infectivity. So healthcare workers, they need to wear personal protective equipment, maybe gloves, masks, goggles, and protective clothing to escape from this virus. And due to the long-term and prolonged use of PPE came a second mini pandemic, the pandemic of occupational dermatosis due to this PPE use. And many adverse effects have been noted. So what is the pattern of the skin change due to this COVID-19 pandemic in healthcare workers? It basically included two broad categories. First was the skin change due to the hand hygiene practices, and the second was due to the prolonged use of these PPEs. Due to hand hygiene practices, maybe the frequency of the sanitizer use has gone up. And the second, the frequency of the hand washing that was normally much lower in the healthcare workers, it has also gone up. And the second is due to the prolonged use of PPEs, maybe gloves, masks, or the other full body PPEs. Due to the hand hygiene practices, mostly we use soaps and these alcohol-based sanitizers. And according to the CDC, they are the cheap, effective, and the simplest form of defense against this COVID-19 virus. But the excessive and the non-judicious use of these soaps and these cheap methods of protection from this COVID-19, they cause disruption of the skin barrier. They may lead to various problems in the skin. The normal commensal, the normal biome on the skin too gets depleted due to the excessive use of these hand hygiene measures. Also, the skin pH gets disturbed, and these highly alkaline soaps, the basic process of the soap formation, that is the saponification, it in itself, it contains certain allergic and irritant components that on prolonged use and that on repeated exposure may lead to disruption in the skin pH balance and the integrity of the skin itself. So what are the common allergens and the irritants? that are present in these soaps and antiseptic solutions. Common allergens may be in the form of fragrances, polyethylene glycol, chloroxylenol, chlorhexidine, and the common irritants, that is the basic saponification process, that lye that is used, that is sodium lauryl sulfate, that may act as an irritant, cetrimide used in the medicated soaps, that may act as an irritant, chloroxylenol or sodium hydroxide used in the saponification, that also may act as an irritant when we do repeated exposure to these soaps and antiseptic solutions. So how did this hand eczema basically present in the COVID-19? It had certain clinical features like this hand eczema. It was more commonly seen on the knuckles and the web spaces, where basically these allergens and the irritants, they tend to accumulate. And together with the predisposing conditions, like we are wearing the gloves, so moisture occurred, occlusion under the gloves, friction associated with the maybe tight fitting gloves or other things. And the other important thing is the atopic dermatitis that may be already present in some healthcare workers. So what are the common signs that were present? Vesiculation was seen, like in this patient, we can here appreciate the vesicles were present on the fingertips, generalized erythema was present, and these scales or erythema, it was most commonly seen on the knuckles, we can see here, or the web spaces. So pruritus occurred, erythema, vesicles, scaling, and in certain cases, urticaria and angioedema have been reported due to this COVID-19 pandemic, due to the excessive use of these soaps and sanitizers. So what was the sequel? There occurred lichenification, pigmentation, fissuring of the skin. These are some of the pictures taken from our department. This was an anesthesia technician. He categorically related it to the excessive use of soaps, and normally he used to wash his hands 5 to 10 times a day. But being an anesthetist, he now if we told him how many times, it was innumerable times. In a 6-hour duty, he used to wash his hands almost more than 30 to 40 times. This is again another healthcare worker, and it shows here scaling and these erythema that is more common on the knuckles. This site was peculiarly involved, site of hand dermatitis in this pandemic. Again, this was a healthcare worker, a doctor, a close friend, and she had this scaling and dryness, and she also attributed it to frequent hand washing. In fact, she was saying that she was getting an OCD type of like frequent hand washing, and due to this COVID pandemic. This was a nursing orderly in our working in a general ward, not in a COVID facility. He had this hyperkeratosis, in fact, erosions. He did have a preceding history of hand eczema, but this was increased due to the use of these sanitizers and soaps. The other thing that caused a concern in this pandemic was gloves. That was never a concern before. The latex gloves commonly used by the healthcare professional, if they are used for the prolonged period of time, they may cause certain, and given the conditions that we work in, it may cause increased sweating, maceration, and it may also cause allergic reaction to the gloves powder that is present there. Allergic reaction in the gloves has been attributed mostly to this thiouram in the rubber mixtures or the other rubber accelerators like Carbamix, etc. Immediate hypersensitivity to the latex has as well been reported. The other thing that is of concern is the sterilization of the gloves that is usually carried out by gamma irradiation. That what it actually does, it may increase the bacterial endotoxin levels that may itself cause the skin irritation and add to the burden of the already this hand dermatitis or contact dermatitis in this COVID era. And there was certainly a certain subset of the patients that reported the worsening of their pre-existing hand dermatitis. Maybe they attributed it more to the occlusion and the maceration. This is one of the healthcare workers that shows the hyperkeratosis and fissuring, and he attributed and generalized erythema. Here we can see it was mainly due to the gloves. This was again one of my colleagues. She was a resident in our ward, and she reported these vesiculations on the dorsum of the hands, although she was posted in the these general wards, not in the exclusively COVID facility. The other thing that is of concern nowadays are the masks. Three types of masks. Masks are generally worn. As healthcare professional, we don't use homemade cloth masks, but maybe at times when we are at our home or we are with our near ones, we do use them. And these masks don't provide adequate protection from the virus, but they may cause irritation due to the friction and humidity. That basically depends upon the textile fabric and the dyes that are used on this fabric and the formaldehyde textile resins, and they are a known cause of allergic contact dermatitis due to these textile masks. These are two, they are working as nurses in our hospital. They reported the exacerbation of these atopic dermatitis and mainly contributed it to these homemade masks. Now about the surgical masks. Surgical masks, they are single-use masks and they provide adequate protection from the virus. And if we see from the dermatological point of view, they are relatively. But the rubber that is used in the elastic straps may cause allergic contact dermatitis due to the thyram in the rubber straps only. And the other thing that's of concern was the aluminum clip in the aluminum in the nose clips. That may cause, first of all, allergic contact dermatitis to the aluminum itself, or the irritant contact dermatitis due to the compression or the friction by these aluminum clips. But however, these have been reported to be only temporary. The other thing that's of concern that came with this COVID-19 pandemic was the use of these N95 masks and respirators. And they provide, N95 means that they provide 95% of the protection, and this protection came with a heavy price. Like they have a tight fit and they cause mechanical pressure and friction, leading to the irritant contact dermatitis. There are certain components in these masks, like they are the products used for the purification of these masks, like formaldehyde and the other derivatives. They may cause aluminum, they may cause this allergic contact dermatitis, and along with this, they have to be tight fit, and the aluminum in the nose clips may have caused severe types of allergic contact dermatitis in healthcare workers. These show the simple indentation due to the N95 mask and the facial erythema or facial suffusion that is noted on the prolonged exposure of these N95 masks. And this is one of our residents. He was working in the ICU in a COVID facility. He had to work continuously. So he had this scar on the bridge of the nose, and it was due to the excessive pressure of the mask and the hardness of the metal clips. And despite having this thing, he had to continue his work in the COVID facility. The other thing, it's basically a new term that has been coined during this pandemic, is a mask. It is actually a type of acne mechanica induced by the mask, maybe due to the textile skin interactions. What basically happens, there occurs a disruption in the microbiome due to the occlusive microenvironment. The new, it creates basically wearing of the mask continuously creates a new intertriginous area. That's our face. And the microbial communities, including the Staphylococcus, including the Corynebacterium that previously used to infect the intertriginous areas, have been seen to occupy this area of our face. There are certain factors that that determine this mask acne. There are mainly the textile skin interactions, like the breathability, stickiness sensation of these masks, moisture sensation, and the maintenance of the hygiene under these masks. These are some of the colleagues. It represents the typical site of the maskne, like the covered area of the face. Acne only appears or these areas, or sometimes what happens, acne is already present there, but it gets exacerbated due to the wearing continuous use of these masks. The other thing that I would like to talk about are the full body PPEs. This is a picture of one of the residents. They had to, despite being in dermatology, they had to give their COVID duties. And this is the type of PPE they used to wear continuously for 6 to 8 hours. Imagine, they did not have the facility that they could change it after every maybe 2 hours, 4 hours. They had to continuously wear. impact. And the extended use of PPEs like this type of full body covers, goggles, headgears, cars led to many dermatological manifestations. The use of these PPEs, they are usually made up of plastic or the other type of things that are impermeable, and it caused increased sweating, occlusion, leading to malaria as well as fungal infections. The proportion of the fungal infections, already the fungal infections are so prevalent today, but it increased drastically in the healthcare workers due to who are used to wearing these full body PPEs. They reported increased tinea pedis infections, also tinea crudis infections. They were drastically increased among the healthcare workers. The use of the goggles and the headgears also came with friction and mechanical occlusion, leading to friction dermatitis, and also these goggles, it caused the allergic contact dermatitis, maybe the rubber in the straps of the straps, etc. Some of the healthcare workers who used to work in exclusive COVID hospitals or exclusively COVID wards, they use these rubber boots or plastic boots, and it also caused allergic contact dermatitis on extended wearing, besides causing increased propensity of these fungal infections. So this is a small questionnaire that we had. It was a small questionnaire-based study that we conducted in our hospital just to determine the pattern of the occupational dermatosis in healthcare workers in this COVID-19 pandemic. It was a Google questionnaire. It was conducted in healthcare workers, and healthcare workers included doctors, nurses, other hospital employees that were concerned directly with the patient care. An institutional ethical committee clearance was obtained verbally for this study. A total of 168 responses were obtained from the healthcare workers, and a questionnaire was formulated to collect the relevant data. This is the questionnaire, this is the Google form that we had circulated, including the age, certain demographic variables, then the department, and the type of the PPE they wore, duration of the mask they wore per day, and it also included the certain signs and the symptoms that they perceived, underlying allergic predisposition, and what treatment they took for this, and how did it affect their quality of life. In this study, mostly there were females, 97 females were there and 71 males only, and 13.9% of these healthcare workers had allergic predisposition. Most of these healthcare workers, they were young residents in the age group of 21 to 30 who filled up our forms. The second group was 31 to 40-year-old persons, that they constituted 37% of the healthcare workers that responded to our questionnaire. Only 6 persons were above the age of 50 years that responded to this questionnaire. Basically, most of the healthcare workers were doctors. It may have a bias here because it was an internet-based study. It was a questionnaire-based study. Maybe the nurses, they don't respond to such, and we don't have so much of contact with the nurses. And ward boys and technicians, they also formed a smaller chunk. This may be a bias in this study because most of the ward boys, they could not operate, they could not use this, or the nursing orderlies, they could not they didn't know how to use this questionnaire. Okay, so, and most of the healthcare workers, they use the N95 mask. As high as 81% use the healthcare workers use N95 masks only. So what was the type of PPE worn? 46% of the patients, 46% of the healthcare workers use gloves. Sanitizer was used by 36% of the healthcare workers. Basically, here again, it is a bias of this questionnaire because most of the healthcare workers had not responded to all the questions. Right. The site of involvement, nasal bridge, that came as the most common site of involvement due to the PPE use. It was reported in as high as 60% of the patients. Hands were the next common site of involvement in as high as 50% of the patients. Then again, cheeks and chin, mostly they reported facial suffusion or the exacerbation of the acne. Then forehead in 16.2% of the patients, and retroauricular area in 13.5% of the patients. These were the symptoms that were reported by these healthcare workers. Most of them came up with only redness, rash, or erythema sort of thing, and as high as 60%, 57%, they came with a single complaint, like they had more of the itching was aggravated. They had more of itching by wearing these PPEs. Dryness was reported by 56% of the patients. Burning and pain was reported by a small minority of them. Erythema as a sign of contact dermatitis was reported in 42% of the patients. There were patients who reported erosion, scarring, urticaria, papules, pressure indentations. Again, it was very common. Some of the patients did report with redness of the eyes and lacrimation and rhinorrhea due to the use of PPEs. Average duration for which the PPE was used, most commonly it was used for 4 to 6 hours, and there was a certain, like 70% of the healthcare workers used the PPE 4 to 6 hours per day, but there were certain like 14.5% of the healthcare workers who used it for greater than 6 hours. And the type of dermatosis they reported, mostly it was the hand dermatitis. Hand dermatitis was the single most common type of dermatosis, that the contact dermatitis that was reported due to the use of PPE. Then again, it was maybe some reported irritant contact dermatitis, some allergic contact dermatitis. There were reports of sweat dermatitis. There were reports of this maskne or the facial acne that was exacerbated in these patients. Retroauricular involvement and lip-lick dermatitis was also reported. So what about we in this questionnaire, we asked the healthcare about what did they do for this PP-induced dermatitis, and the answer was that most commonly no treatment was taken, that they did not find this dermatitis, PP-induced dermatitis, was some of the healthcare workers use topical moisturizers. So basically, this is a pain scale, but to make the questionnaire easy so that everyone could respond to this questionnaire, I used this pain scale so that the healthcare workers could just decipher how did it affect the quality of life. And most of them, they were like balanced, not so happy with this, but only it caused severe quality of life impairment in only 6.3, like 3%, 3 to 6 point. If we add it up, only 9% of the patient, 9% of the healthcare workers were severely affected by this PP-induced dermatitis. So what were the limitations of this questionnaire? Basically, prevalence cannot be determined by this study because there are the higher rates of participation by the healthcare workers with only the skin complaints. There was a language barrier. This questionnaire was in English, and most of the nursing orderly or the other staff, they could not attempt this questionnaire. And at some times, they did not have an internet access to. Sample size was also very small. Maybe we had, although we had circulated it to a vast majority of the healthcare workers, but maybe non-participation because they were already preoccupied in this pandemic. And so our results, they actually reflect a small portion, and it's a potentially biased reflection of the true opinions of all the healthcare workers. Again, the patch test was not done because it was, with this questionnaire was based only upon the Google survey. So what we as dermatologists, what do we have a role, how we can take care of this PP-induced dermatitis? We have to educate our fellows, like this, these N95 masks, the straps, they should not be worn around the ear. They may cause, because of the tight fit, it may cause irritation of the retroauricular and the irritation and erosions in the retroauricular area. It has to be worn like this on the crown of the head. It should not be sitting on top of the ears. And in certain cases, like the photograph of the ICU resident that I have shown you, what we advised to them, that even if they continue to work for in their ICUs, they should put prophylactic dressings, maybe thin hydrocolloid dressings or the thin foam dressings underneath these masks. And maybe they should use the surgical mask underneath this PP, so that the direct contact with these aluminum strips, it is avoided. And the facial PP kit, it should be of correct fit and the correct measure. It should be of moderate tightness, like we should gently pinch this metal clip at the bridge of the nose, so that it does not irritate the bridge of the nose. And the other thing, that is adding of the surgical mask to line the inside of these N95 masks. Now about the gloves, what we can advise to our fellow healthcare workers is, like, we can line the inside of the gloves with a fragrance-free light emollients, or we can advocate the use of, if they have a latex allergy to the gloves, nitrile gloves can be used. And these nitrile gloves, they basically lack this molecular credentials to open the cellular doors. In very rare instances, it has been reported, like CDC does not have a sample size so that it can report allergy to these nitrile gloves. So we can advocate their use. We can also use plastic or maybe fabric gloves inside these latex gloves. And the other thing, this was an idea that we shared in our department. One of my residents came with this, that, ma'am, why can't we do, like, we can reverse the gloves so that the latex that lines inside of these gloves powder, it comes outside. Sometimes we did advise our fellow colleagues, like, if they did not have access to these nitrile gloves or other things, just reverse the gloves so that the latex remains on the outside. About the management, these adverse reactions, they are usually mild, and most of the healthcare workers, literally speaking, they did not seek care, and they continued to use the PP equipment. And the wearer that will not seek the help of a dermatologist, or at most of the times they did self-medicate. But we can divide it into three categories: mild, moderate, or severe. In mild cases, we can only advise, like, decrease the frequency of the hand washing and the sanitizers. Barrier creams can be advocated to use, and topical fragrance-free emollients, they should be used, because if we use the fragrance emollients, maybe due to the use of these PPs, they may cause increased this allergy contact dermatitis in these healthcare workers. And the correct fitting PPE is also very important, because if the fit of the PPE is not correct, it may cause additional, apart from the allergy contact dermatitis sort of thing, it may also cause maceration, occlusion, and it may cause dryness, or
Ma'am,
maceration
we
and
are
occlusion,
running
and it may
out of
aggravate the.
time. Please be fast. We are running out of time, ma'am. Please be
Okay,
fast.
okay, so after that, the mild, those healthcare workers that had the mild involvement, they did use topical mid-potency topical steroids or anti-allergics, and in severe cases, some had to use oral steroids or PPE-free periods were advocated for them. The take-home message is that although there is no doubt that the threat of COVID-19 is still there, but the possible solutions can be proposed to the healthcare workers who are still fighting COVID-19 to effectively reduce this adverse skin reaction due to the PPE. And the second thing, we as dermatologists, we can have our say in the like in the governing bodies, so as to use the bio-friendly textiles for the masks, gloves, and full PPE dresses. Thank you.
Thank you, ma'am. Thank you, Dr. Shazia Jeelani, ma'am, for enlightening on a very common subject. And now for the next session.
Thank you, sir. Thank you, ma'am.